With respect to absorption of calcium, if you have a higher intake, a lower proportion is absorbed. A reduced calcium intake leads to enhanced absorption. And basically, this is mediated by parathyroid hormone and vitamin D feedback. In other words, if I already have a high blood calcium level, do I want to absorb a bunch of calcium? And so you won't, because of the feedback mechanisms on this. If I don't have much blood calcium, I want to try to absorb as much as I can. So these two hormones together regulate that. Okay? Now this is just showing you the renal regulation of calcium here. Calcium excretion is controlled by basically variations of your renal tubular absorption. If you notice it in the proximal tubule, reabsorption of calcium is linked to sodium absorption and volume status. In other words, PTH doesn't work there. Because what's the most active part of the tubules? The proximal tubule. It's got the thickest epithelium, most brush border and everything. That's where most of the solutes and the solvents are absorbed. Okay? Now, but that may not be fine-tuned enough. You may need to get more. And that's where PTH comes in hand. Distal tubular, the absorption of calcium is PTH dependent. And it's through a sodium-calcium exchange mechanism. Okay? That's down the distal tubule. So that's the fine-tune. In other words, the distal tubule is, in the collecting ducts, are fine-tuners. They account for things that may need to be further done that weren't done in the proximal tubules. Okay? Now, as far as its bone regulation of calcium, if you look at the bone, the green part is the internal of the bone, okay? And you can see that you've got calcium. What's calcium doing as far as PTH in that bone? What's it doing? It's coming out, right? What's vitamin D doing to the calcium? It's putting it in, okay? And so basically they are antagonistic at that point. Now, the activation of vitamin D in the kidney requires PTH. So if I do not, so the PTH is released, that's going to activate the vitamin D. Vitamin D acts as a negative feedback to shut off the effects of PTH on the bone. Okay, so they work synergistically like that. They're basically antagonistic. It's negative feedback mechanism. Okay? But if we have problems with the kidney, what's going to happen with the activation of vitamin D? It will not occur. So what have we done to the feedback mechanism for PTH? We've lost it. And so that's why it will keep pulling calcium out the bone, keep pulling it out, because it's not shut up, or shut off, rather, not shut up, or shut off. Okay? All right, so now that's not a butterfly up there. That's the thyroid, okay? All right, but you can see this is basically showing you the effects of each one of these things upon the various mechanisms of calcium regulation. Okay, we've already gone through this, so I'm not going to do to it, but again, just remember what the main purpose of each of those hormones is. Okay? And that way you can figure out what's going on. If calcitonin wants to, keep lower blood calcium levels, is it going to cause lysis of bone? No. So you just know what their main purpose is to do. You can figure out what their effects are upon the various tissues. Now, parathyroid glands. Most of your domestic species have two pairs of parathyroid glands. One's located near the pole, one on each one of the thyroid, located at the pole, and the other two are internal. How many of you found the internal parathyroids? How many of you found the external parathyroids? How many of you just took it for granted that they were there? Okay. Because what did I tell you about their size?
They're small.
They're small compared to the thyroid, aren't they? So sometimes it's hard to find them. All right. Now, basically, the pig, though, has only one pair of parathyroid glands, and they lie anterior to the thyroid. They're not associated with the thyroid. If you look at the cells which are mainly producing this, the chief cells are the active hormone secreting cells in there. If they're inactive or degenerate, they're called oxaphyll cells. Okay? Now, this is just showing you this is a human, and so this is kind of idealized, and that those internal ones don't stand out like that. But it shows you the relative size of these parathyroids to the thyroid. So what's the most common cause of hypothyroidism in cats? Surgical removal for hyperthyroidism, right? And when you take them out, if you're not careful, what are you also going to take out? Parathyroids. So hopefully you can dissect around and leave the external ones there. Forget the internal ones, you're not going to be able to get those. They're going to come out. But one or two will be able to take care of things. But again, I told you the other day, if you have to take it, if you can't save them like that, and you get them all out, then you can dissect them out, sterilely mince them up, and inject them back into the precothyroid area, and hopefully they'll reanastomose the blood supply, and you'll basically make a parathyroid. Okay? And it's usually successful, sometimes not. Okay? Now, this is just showing you the species differences. If you look down there at the bovine, again, they have two pairs, but two of them are at the anterior poles of the thyroid, and the other two are anterior to that. If you look over there at the pigs, see, they just have the two that aren't associated with the thyroid, they're in front of it. If you look at the, pardon me, the equine right there, you see, what about the equine? They're at the first rib, okay, and that they're basically, they're not associated with the thyroid per se. They're caudal to the thyroid gland, basically, in there. And the other species are very similar as far as if they're rumen or something, they're similar to the cow. The feline and the dog are very similar as far as where they are, okay? So again, you know, one of the things that we see as far as taking these out, if you've got, what if I got some traumatic damage to the area? Can I interfere with both thyroid and parathyroid function? Mm-hmm. And it will vary how severe depending upon where it's located and what species you're talking about. Okay. Also, if you got a tumor in them, does it matter where they're located? If you got a big tumor making them get huge? Yeah, what if they're back there near the thoracic inlet? What can they do? Close off the thoracic inlet? Is that compatible with life? No. So again, the severity of the lesions in these will vary with species depending upon location. There's a normal parathyroid up there. See, it's just a regular endocrine organ. Got your little clusters and clumps of endocrine secreting cells. High vascularity in there. Now, as far as the synthesis of parathyroid hormone, it's a peptide hormone. So the steps are similar to what we learned for peptide hormones in there. The dominant regulator of its release, the synthesis and release, is ionized blood calcium levels. That's what controls it. Okay? Hypocalcemia will stimulate and hypercalcemia will inhibit PTH release. So that's the regulatory feedback mechanism. Okay? Now, the maximum secretion of PTH will occur at plasma calcium levels below 3.5 milligrams per deciliter. Okay, and that's ionized calcium. That's after you've corrected for the albumin and all that kind of stuff. If you get that, then that tells you that you're going to have as much PTH trying to help as possible. At calcium, ionized calcium above 5.5 milligrams per deciliter is maximally inhibited. Now, that doesn't mean the total calcium is that. It means the ionized part of calcium is that. Okay, it's going to be that high. Now, vitamin D3 inhibits PTH gene expression. That provides you another level of feedback control. In other words, remember, parathyroid hormone is necessary for the activation in the kidney of vitamin D3. Its levels go up, feedback mechanism shuts off your PTH. Okay, so it's very integrated, because calcium is extremely dangerous if you don't control it. I mean, what did they replace? Do you remember your warfarin toxicity, rat poisons? Cause the animal to bleed to death, right? What did they change? What did they go over to stop this bleeding problem? They went to cholecalciferol poisons, which is hypervitaminosis D. And what kind of problems can you get with hypervitaminosis D? Hypervitaminosis D will cause marked elevations in blood calcium level because you're pulling it out and you're not getting rid of it and everything. And what will that do to the heart? What's hypercalcemia do to the heart? You get severe tachycardia, and what can that lead to? LOL. So that's how it kills the animal. Now, there's a problem like that. That can happen within minutes after ingestion. So what does that say? If a client has a dog that ate that stuff, how likely are you going to get to you before it's dead? Where with warfarin toxicity, it's slower. And if it gets to you, you might be able to bring it back all right. So that's one thing where they try to get around one problem. What did they do? Make it a worse problem. One thing, though, is the cholecalciferol rodenticides aren't as tasty as the warfarin ones. And so the animals not as many animals will eat them, but that dumb animal that does, forget it. Okay? All right? Now, again, serum phosphate concentration doesn't have a direct regulatory influence on synthesis and release of PTH. It's the calcium-phosphorus ratio that does that. Because it's going to lower the ionized calcium there. That's going to trigger PTH to be released. And that's why if that normal ratio is about 2 to 3 to 1, if it's 1 to 4, then you're going to have the, even if the calcium levels are normal, the parathyroid is going to interpret that as needing more calcium. And so put more calcium out there. This is just showing you how the, regulation of PTH, the y-axis is the PTH secretion, the x-axis is the plasma ionized calcium. And if you notice, it's a very rapid response, but if you see that at 100%, you can see the ionized calcium down there is building up, right? But what if you don't have any secretion? What happens to that ionized calcium? In other words, what we're doing, if the ionized calcium is greater than 5.5, what's it doing to PTH secretion? Decreasing it. If you go back the other way and see when you get below that 5.5, what starts to be released? The PTH. And then when you get over there so that it's, the calcium levels have basically really decreased, and there's going to be maximum secretion. It's just showing you that there is an indirect response as far as calcium levels increase, PTH levels decrease, and vice versa. It's an indirect or inverse relationship there. But it's very sensitive. Notice the very narrow part where you drop real quick. It's very sensitive. Now, PTH will respond, as you can see by that, to small alterations in plasma calcium within seconds. All right? Now, a unique calcium receptor within the parathyroid plasma membrane can sense changes in your extracellular fluid concentrations of ionized calcium, and they're very sensitive to minor changes and stuff. It is a G protein receptor within the parathyroid cell plasma membrane, and this calcium, the calcium inflow, and it can detect how much calcium it's getting, so then it can determine whether or not it has to respond. Now, in normal and hypercalcemic states, that G protein coupled receptor will activate a phospholipase C, which inhibits the adenylate cyclase, which results in increased intracellular calcium. And what's that going to do? If you got increased intracellular calcium in those parathyroid cells, what's that going to tell them they don't need? They don't need to secrete PTH. And so it's the second messenger effect that calcium actually initiates within those parathyroid cells. Now, in hypocalcemic states, that cyclic AMP increases, and that's going to increase PTH secretion. So you see, it's multiple steps that are inside that thing. But all y'all really need to know is that if I have low blood ionized calcium, what's that parathyroid going to do? The cells are going to detect that the ionized calcium is low because it's not coming inside of them. And so it's going to release PTH. And vice versa, if there's too much, that's going to get into the cell and say, I don't need any more. Shut off the PTH. Okay? That's basically what's going on. So what's the overall action of PTH as far as calcium is concerned? To increase plasma calcium, ionized calcium, and decrease plasma phosphate levels. Doesn't reabsorb it by the kidney, right? And so that keeps that calcium-phosphorus ratio in a closer balance, and you have adequate amounts of ionized calcium out in the blood to do what it's necessary to do. And what's calcium do? Almost all enzymatic reactions require calcium. Can you live without enzymatic reactions? No. No. Normal cellular respiration and stuff requires calcium. So that's why it's so. That's why there's more than one hormone that regulates things, because you have to have a backup mechanism if you need to, and that type of thing. Okay. Now, as far as PTH, as we said, acts directly on the bones to stimulate calcium, ionized calcium, and phosphate. Has to pull them both out. And remember, that also requires vitamin D3 to do this, because that activates some of the receptors in the bone. It acts on the kidney to increase calcium reabsorption in the distal tubule, inhibit reabsorption of phosphate in the proximal convoluted tubule, and to increase the conversion of that 25 hydroxyvitamin D to 125, which is the active form. Okay? As far as what this is going to cause is basically an increased excretion of phosphorus in the urine. And also it will affect, since you got to pull the calcium in, if calcium comes in, if a positive comes in, what has to go out in exchange for it? Another positive. And so it's going to excrete things like, first it wants to go with potassium if it can. Okay? It's also, now the problem with the bicarb, if you put hydrogen out there, sodium out there, you get sodium bicarb, and that's going to inhibit the reabsorption of bicarb from the kidney. But is it worried about the bicarb right now, or is it more worried about that calcium level? More worried about the calcium level. But if you can see, what if I have hyperparathyroidism? What's going to happen to my blood potassium levels? We get hypokalemia? What's hypokalemia cause? What's hypokalemia cause? Well, how? Hypocalcemia doesn't really affect the heart. Hypocalcemia affects all the peripheral muscles and things like the diaphragm. They don't work. You collapse. Diaphragm not working very well. Is that going to maintain longevity, or if it keeps up, what's going to happen? The animal dies. Okay. Now hyperkalemia is what causes the heart effects. Okay. What about bicarb? If I can't maintain my bicarb, what's my blood pH going to do? It's going to be acidic, which will help my calcium levels, right? But there's only so much acidic blood you can get, right? Without death, okay? Of course, with sodium, if you're losing sodium, what can you interfere with reabsorption of? Water. And you lose some of your ionic gradients and everything else, so you're going to have problems in there. It also increases the excretion of cyclic AMP. What's cyclic AMP used for? It's also made to make ATP and stuff, right? Can decreasing ATP production be a big problem? Yes. Yes. And so in amino acids, we need amino acids to make proteins and all that stuff, don't we? So you can see why just one endocrine organ can cause all kinds of problems as far as the whole body is concerned, isn't it? That's what makes them so fun to try to diagnose, because they all overlap. Okay? Now, it decreases urinary excretion of magnesium. Can hypermagnesemia give you problems? Yeah, it can. It can mess up cell membranes and all this type of thing. Hypomagnesemia can also. And what's hypomagnesemia? I can't say that very well. What's hypomagnesemia called in cattle? Anybody? Furs in the spring? Animals around lush green pasture? What about grass tetany? And what's tetany mean? Like that, right? So does that tell you that if you're losing magnesium, you may have some problems with tetany? And why do you get tetany with low magnesium level? Worse, if you're doing this, what does it mean? What area are you affecting? The neuromuscular junction. If you're seeing this, what are you doing? You're releasing, you're leaking, you're releasing acetylcholine, it's causing the contraction, acetylcholine esterase is coming in and breaking it down. But is that going to be a nice, what if that's the diaphragm doing that?
You did.
You're dead, right. Okay?
What did you say, hypermagnesemia?
Hyper can cause the opposite effects. It can stabilize that neuromuscular membrane so much that you can't leak out the acetylcholine. So you can get kind of a flaccid paralysis with it. It can also cause severe problems on the heart, irregular heartbeats and all this type of thing. And it can interfere with other cations and things in the body. Okay? Now, what about ammonia? What about not getting rid of ammonia? What can that cause? What about hepatic encephalopathy? And what can that cause? Death. Okay, brain death. Well, some of us may have brain death already, but you know, it's all overload, right? But brain death is not very good with life, is it? Okay. And you can lose basically acids also. They build up, so that's going to further aggravate the blood pH, make it much lower. Okay. Now, as far as PTH, as we say, it indirectly stimulates intestinal calcium absorption, and this does this mainly through its effect upon vitamin D3, and so that the vitamin D3 can go over there and make those carrier proteins to pull calcium in. There is some little direct effect of PTH on the intestines, but it's minimal compared to what the vitamin D is. Okay. And And this just summarizes those actions of PTH and what low concentrations of calcium in the blood causes the release of the parathyroid hormone. And what's the effect upon bone basically is to efflux. What's efflux mean? Pull out. Influx means to push in, right? So efflux of calcium out the bone, decreased loss of calcium in the urine, enhanced absorption of calcium in the intestines. So what's going to be the overall effect? Increased ionized calcium levels in the blood. But you can see if you have a tumor secreting too much and you exacerbate all those things, what can happen as far as blood calcium levels and what can happen as far as the animal's condition. This is just showing you a flow chart showing you basically what PTH along with calcitonin and 125 do. So as far as they're regulating, and they work together to make sure that the ionized calcium levels is an acceptable normal limit. Okay? And this little summary here tells you a summary of PTH. Basically, it summarizes what we just talked about. What have I told you about summary slides? Good idea to review them. If there's a question on them, then come ask or read. Okay? But it shows you that the physiological effect is increasing the extracellular fluid level of ionized calcium. Okay? And how you measure it? You measure it in 1 ml of serum by radioimmunoassay type things. Normal values will differ depending upon which laboratory is running the exact same test. I know it's not right, but that's what happens. So you never send to one lab and then interpret those values from results from another lab. You have to interpret from the results from the laboratory that does it. Okay? And interpretation, increased PTH levels indicate primary or secondary hyperparathyroidism. Make sense? Now, what if I have hypercalcemia and my PTH is high? What's that tell me is probably causing the hypercalcemia?